Начинаем, да?
Ну, видимо, да. Я свою презентацию здесь зашли. Page down, page up?
Да, да. Ну, ссылки вверх, вниз. Когда закончите, совершить трансляцию.
Такой кнопки вверх, не нажимать. Пожалуйста. Извините.
Good morning, dear students. There was some difficulties, technical difficulties. That's why I start my lecture a little bit later than I must. So today's topic is rheumatic fever. What is it? It's a non-separative acute inflammatory complication of group A streptococcal pharyngeal infection causing combination of different clinical manifestations like arthritis, carditis, subcutaneous nodules, erythema marginatum, and phoria. It's a classic clinical signs of rheumatic fever. So usually people between 5 till 18 years old are affected by this disease. Very rare elder one can be affected by rheumatic fever. So these are the classic age periods in which we see manifestation of rheumatic fever in children and in adolescents. Males and females equally affected by rheumatic fever. Near the half of patients with rheumatic heart disease don't know anything about this previous acute rheumatic fever in anamnesis. The most often joints, heart, skin, and nervous system are affected in different combinations in rheumatic fever. It must be associated with recent infection. It can be pharyngitis more often or some skin infection like pyoderma. So in anamnesis, you may ask the patient about previous infection and it must be present. About 50% of patients with rheumatic fever have recurrency if they have another episode of streptococcal pharyngitis and was not treated. So relapse or recurrency of rheumatic attack, it's a big problem because in a time we'll see problems with valves and due to carditis and formation of chronic rheumatic heart disease. So what is group A beta hemolytic streptococcus? So after this infection, we see clinical manifestations of rheumatic fever near to 2 to 6 weeks. Host immune response take place and take a big role for manifestation of rheumatic fever. Also, it must be special strains of streptococcus, which we call rheumatogenic serotypes of streptococcus, because there are some nephrogenic serotypes and they cause glomerulonephritis. And there are some important antigenic proteins in external layer of streptococcus. M, T, R proteins, which are the most antigenic and cause cross-reaction. So you see the scheme of streptococcal body and where these proteins, antigenic proteins, are located. So as we said, M proteins are the most antigenic. The same M proteins are present in synovium, heart muscles, and heart muscle and heart valve. That's why we see these cross reactions, immune cross reaction. And there must be present of genetic host factors. You see what are they to push this abnormal autoimmune reaction, which we call as mimicry reaction and cross-immune reaction in case of rheumatic fever. So antibodies which forms because of normal immune response, they cross-react with the M proteins which are localized in myofibers, in cardiac myofiber protein, myosin, in smooth muscles of arteries, and as we say, the same M proteins are present in joints, in skin. So we see release of cytokines and tissue destruction because of cross-reactivity of type 2 and the mechanism which we see in rheumatic fever called as molecular mimicry because of similar M proteins and antigens in normal tissue and in streptococc. So histopathology, what are the specific changes in affected tissues in rheumatic fever? We divide some specific signs which we may see in biopsy material. So it's Aschoff's bodies, it's small granulomas around necrotic changed collagen. Around it, we see T cells, macrophages, and myocytes. Also, we may see Aschoff's giant cells. It's multinucleate macrophages, also in the area of inflammation, and so-called Anichkov cells or caterpillar cells, in which are enlarged macrophages. And you see in picture, so this is caterpillar cells or Anichkov cells, and these are Aschoff's bodies. The same about in B, in picture B, we see Aschoff giant cells, and in picture C, we see the same Anichkov cells or caterpillar cells. So these are the features, morphological features of rheumatic fever. So what are the main clinical features? More often it's sudden onset of fever, pale malaise, about 2-3 weeks after previous streptococcal infection. As we said, more often it's pharyngitis. Another main symptoms are arthritis and arthralgia, scarditis, Sydenham chorea, erythema marginatum, and subcutaneous nodules. So we call these 5 signs as a major criteria of rheumatic fever. Other signs, it's arthralgia, as I said, is epistaxis, serositis, polyserositis sometimes can be, and sometimes in severe and aggressive immune response, we may see involvement of lungs, pneumonitis, kidneys, nephritis, and central nervous system with sometimes encephalitis. So what do we know about arthritis? Arthritis more often is the most often symptom of rheumatic fever. Near to 80% of patients has arthritis. So it has migratory characteristics because it appears in one of your joints, then resolve and appears in another joints. It seems to be that inflammation and pain migrate. So it most often has short duration and excellent response for salicylate. If there is no response for salicylate, we must think about another possible reason of arthritis. Usually more than 5 joints affects, and more often it's large joints. So rheumatic fever preferred knees, ankles, wrists and elbows. More rare, we may see involvement of shoulders, hips and small joints of hands and feet. As I said, migratory is characteristic of arthritis, rheumatic arthritis. More often it's polyarthritis, as we said, more than 5 joints, but in adults sometimes can be single joint inflammation, so you need to differentiate with other diseases. Usually subside within 2 weeks, seldom lasts for more than months. And no further residual deformity, no real affection of joint. Carditis. It's maybe rare but more aggressive manifestation of rheumatic fever. It occurs in about 50 to 70% of patients with rheumatic fever. Any part of the heart can be affected, so can be pancreatitis. So as endocardium, as myocardium, as pericardium can be affected in rheumatic fever. More often valvulitis take place. Sometimes can be isolated pericarditis or myocarditis. More often mitral and aortic regurgitation take place, in which we may see apical systolic and basal diastolic murmurs as a result of valvulitis and affection of mitral and aortic valve. As manifestation of carditis because of heart failure, we may see dyspnea with rales, nausea and vomiting sometimes, non-productive cough, fatigue, so general signs of heart failure. If isolated pericarditis take place, so it's usually asymptomatic, but sometimes can manifestate with chest pain and pericardial rub. So these are some pictures for you. These are affection of endocardium in you see focuses of affection, focuses of inflammation in carditis. So as I said, mitral valve is affected in most cases in rheumatic heart disease. Mitral regurgitation, most common found in children and adolescents. Mitral stenosis represents long-term chronic disease, so it's already a result of previous attacks of rheumatic fever. And in adults, we'll see mitral stenosis. And for further remember, you should learn that you should know that the most often complication of mitral stenosis in patients with chronic rheumatic disease, heart disease, it's atrial fibrillation. Aortic valve affects more rare than mitral valve. Also generally associated with disease of mitral valve in patients with rheumatic fever. Tends to develop as long-term complication of aortic regurgitation and less commonly affected tricuspid and pulmonary valves. It's casuistic cases, it's rare cases for rheumatic fever, but also you should remember that sometimes in aggressive carditis, these valves also can be affected. So clinical signs, one more time, of carditis, it's high pulse rate tachycardia as manifestation of heart disease, of heart failure, murmurs due to valve insufficiency and dysfunction. Cardiomegaly can be due to myocarditis and pericarditis. Different rhythm disturbances and conduction disturbances. Pericardial friction rubs and general edema and dyspnea and rales due to heart failure, as I said before. Another classic clinical manifestation of rheumatic fever, which is also one of the major criteria, is Sydenham-Horia. So in it, we will see extrapyramidal disorders. We may see fast clonic involuntary movements, especially of face and lips, inappropriate laughing and crying in children and adolescents, tongue fasciculation or tongue darting, facial grimacing, and explosive speech. So more often, of course, we see it in children, and maybe teacher of the patient of this child can tell his parents that something wrong with his behavior, and it's due to Sydenham-Horia can be. So also can be muscular hypertonus, some signs of emotional lability, and as a first sign can be in children can be difficulty of walking, talking, and writing also. Usually it's a late manifestation, months after infection. Often it can be only manifestation of acute rheumatic fever. It occurs in near to 30% of patients with rheumatic fever. In half cases, it's associated with carditis or arthritis. Usually it's benign and resolves in 2-3 months. And in severe cases, sometimes can be prolonged flow and last for a few years. Another criteria of acute rheumatic fever is subcutaneous nodules. Usually they are not very large, so you see that it's from half till 2 centimeters long. Firm, non-tender, isolated, or in clusters can be. Most common, they localized along extend the surface of joints, and we may see them in the area of knees, elbows, and wrists. So these are photos, how do they look like. So if you see such changes which are associated with arthritis and carditis, of course, your first idea must be about acute rheumatic fever. Also, they can be on bone prominence, tendons, dorsal feet, occiput or cervical spine sometimes. So it can be they can be present for very short period of time, so last for few days only. That's why when patient asks for medical help, there can be nothing already. So they disappear quickly. Occurs in 9 till 20% of cases of acute rheumatic fever and often associated with carditis. So remember that carditis is the most classic and most aggressive manifestation of acute rheumatic fever. Another criteria of acute rheumatic fever, another sign, is erythema magnatum. So it's less common, it's present near to 7% of patients, highly specific for acute rheumatic fever. It has reddish pink borders, pale center, round or irregular shape. Often it's localized in trunk, abdomen, inner arms or thighs. Highly suggestive of carditis. So these are pictures how it look like. So you see these reddish pink borders, pale center, and round irregular shape. So if you see such changes, skin changes, and also they are associated with arthritis and carditis, so you think first of all about acute rheumatic fever. There can be some other clinical features which also take place in manifestation of acute rheumatic fever. So we call it fever. So increased temperature, body temperature. It's also connected with the activity of inflammation, so it can be febrile, subfebrile individually. So arthralgias, epistaxis, sometimes abdominal pain sometimes due to polyceratitis or enlargement of liver in severe heart failure, sometimes because of, as I said, polyceratitis and anorexia. Pneumonitis, as I said, when in aggressive cases there is affection of lungs. Mild pleuritis can be also, and in rare cases, in severe inflammation, encephalitis. So I said it before. So also besides main criteria, also can be such symptoms which also sometimes take place in patients with acute rheumatic fever. And due to it, we need to differentiate this disease with other similar diseases in which we see the same symptomatic symptoms. So these are, as for me, quite right picture how to which can help you to remember what is rheumatic fever. So you see joints, so polyarthritis, you see carditis, you see nodules, you see erythema marginatum and chorea. So one more time, what are major criteria? As I said before, it's arthritis, carditis, Sydenham chorea, erythema marginatum, and subcutaneous nodules. So you see in picture, they are quite bright for remembering. And minor manifestation, it's fever, arthralgia, elevated C-reactive protein, erythrocyte sedimentation rate also increased, and prolonged PR interval in ECG. So how to detect and to put diagnosis of acute rheumatic fever? So if we have two major or one minor and two major or one major and two minor manifestation, we say about rheumatic fever. And if we see evidence of group A streptococcal infection, so how we may detect previous infection, elevating or rising of anti-streptococcal antibody titer, anti-streptozin O, anti-DNase B, positive throat culture, positive rapid antigen test in children with clinical manifestation of previous streptococcal pharyngitis. So if you see the patient with two major or one major and two minor criteria plus evidence of group A streptococcal infection, you may put this diagnosis. Carditis can be clinical and or subclinical. Subclinical carditis is defined by echocardiography criteria. So now, besides clinical manifestation, we must check and we must prove affection of valves by inflammation using echocardiography. So there are some echocardiographic criteria which we use for detection of improvement of carditis. So pathologic mitral valve morphological changes include annular dilation, caudal elongation or rupture with flail leaflet, anterior or less commonly posterior leaflet tip prolapse, or beading nodularity of leaflet tips. And pathologic aortic valve morphological changes also the same, and after echocardiography, you see these changes, which are the improvement of carditis. And there are some Doppler criteria also which we must use for detection of valve dysfunction. And you see what are they. So not only clinical criteria symptoms. You must have instrumental improvement of valve affection and valve dysfunction. So you use echocardiography plus Doppler criteria to prove carditis in acute rheumatic fever. If patients which asked for your medical help has polyarthritis, then polyarthralgia is not used for diagnosis. And also there are some problems with PR interval because sometimes it can be absent. And only near to 35% of children with acute rheumatic fever have these symptoms. So not for all patients, this can be the criteria of carditis of acute rheumatic fever. That's why for improvement of carditis, I want you to remember that we must use more objective data. It's echocardiography criteria and Doppler criteria. So evidence of previous infection, how we will detect it. So recent history of pharyngitis or scarlet fever, positive throat culture, increased or rising anti-streptolizine O titer, antibodies, and positive rapid gas antigen test in children with manifestation of streptococcal pharyngitis. Also presence of some other specific antibodies to anti-DNSB, anti-hyaluronidase, anti-streptokinase. So the most classic, if it is anti-streptolizine O titer antibodies, but also if you have some doubts, you may check for other antibodies. So as I said, to put diagnosis, we must prove evidence of previous infection, and these are methods how you may prove it and detect this infection. CBC for diagnosis is not very useful because maybe there are some unspecific changes, increased ESR, but in general, mostly nothing. Non-specific indications of inflammation, it's increased ESR and C-reactive protein, but also they can be increased due to other inflammation in organism, but in general they can be also a marker of inflammation in acute rheumatic fever, of course in combination, in association with other clinical data. No, as we said, tests for anti-streptococcal antibodies, sometimes X-ray, chest X-ray, in which we may see pneumonitis or we may see enlargement of heart shadow. And in ECG, as we said, in 1/3 of patients, we may see prolonged PR interval as a manifestation of carditis. But there can be some other changes in ECG due to enlargement and dilation of ventriculus and arteries or due to some arrhythmias because of myocarditis. So we should differentiate rheumatic fever with some also autoimmune diseases or different inflammatory process in organism. So more often in children and adolescents, we should differentiate acute rheumatic fever with juvenile and idiopathic arthritis. Sometimes we need to differentiate it with systemic lupus erythematosus, with Lyme disease, with reactive arthritis, with arthropathy in sickle cell disease, embolic bacterial endocarditis, Kawasaki disease, leukemia, and other cancers. Sometimes we should differentiate with familial Mediterranean fever, antiphospholipid syndrome, saccharidosis, serum sickness, and some drug reactions. There are so-called now divide so-called post-streptococcal reactive arthritis. So what is it? It's a development of arthritis after group A streptococcal infection in patients who do not meet with the criteria for acute rheumatic fever. So sometimes there is not enough criteria present in the patient to put acute rheumatic fever, but patient has previous infection and affection of joints. So we may put such diagnosis, post-streptococcal reactive arthritis, and follow the patient's condition to not to miss possible acute rheumatic fever and carditis when we may put already acute rheumatic fever, and put it in time to prevent further affection of valves and formation of chronic rheumatic heart disease. So the biggest problem of acute rheumatic fever is recurrent heart disease. It's chronic rheumatic heart disease, so-called, which is the result of previous relapse of carditis. So chronic rheumatic heart disease is characterized by rapid inflammation with fibrinous resolution. The anatomical changes of valves include left thickening of the tendinous cord. Rheumatic heart disease is the most serious complication of rheumatic fever, as I said. And in developing countries, this disease affects near to 25 till 45% with cardiovascular diseases. I want you to remember that I said before that near 50% of patients with further carditis know nothing about previous acute rheumatic fever. So they ask for medical help already because of mitral stenosis, for example, or aortic regurgitation. After years, when patient has already a chronic rheumatic heart disease and know nothing and have no information, has no information in anamnesis about previous acute rheumatic fever attack. So you see what changes of valves we may see also under echocardiography. What happens with valves? What changes of valves lead to valve dysfunction? And as we said before, because acute rheumatic fever more often attacks mitral valve and aortic valve, so recurrent heart disease, it's a disease of mitral and aortic valve, most of all. Tricuspid and pulmonic valves are seldom affected in acute rheumatic fever. That's why changes of these valves also are rare in chronic rheumatic heart disease. So the most common, as I said, mitral stenosis, aortic regurgitation, and sometimes rare tricuspid regurgitation. More often it's associated with mitral stenosis. So in this picture, for better understanding what is normal mitral valve and what is rheumatic mitral valve with stenosis, you see affection of mitral valve due to untreated recurrent heart disease. So these are a result of previous acute rheumatic fever, which was not treated in time. So what about management of rheumatic fever? So we have four main ways or directions how we may help the patient with acute rheumatic fever. So for approach, we need to treat infection which provoke this disease. We need to treat acute inflammation. We need to treat heart failure if it's present. And we need to make prophylaxis for further infection and further recurrent heart disease. So how we may prevent rheumatic fever? So if patient has pharyngitis or any focuses of streptococcal infection, we may use antibiotics, and we must use antibiotics. The most often used antibiotics is penicillin group, so penicillin, amoxicillin, and sometimes benzathine penicillin G. You see the dosages and the duration. So these are the primary prevention of rheumatic fever if patient has streptococcal pharyngitis, for example. So you prescribe penicillin or amoxicillin or benzathine penicillin G in these dosages. And duration more often is 10 days for classic penicillin and amoxicillin, and for benzathine penicillin, it's one dosage, and you see its dosages depending on the weight of the patient. So with the age of patient, it's correlates. So in patient who has allergy reaction for penicillin group, we may use other antibiotics for primary prevention of rheumatic fever. It can be clindamycin, azithromycin, and clarithromycin. Also, you see the dosage, you may rewrite it to copy it. And sometimes we may use cephalosporins and combination of amoxicillin with clavulanic acid, which is also quite effective for prevention of rheumatic fever. For general treatment to decrease inflammation, to stop rheumatic fever attack. So we may use anti-inflammatory drugs as non-steroid, as steroid. So it depending on the activity of process. So we may use anti-inflammatory agents to control arthritis, to control fever and other acute symptoms. Salicylates are the preferred agents if they are not enough effective, or if you see severe activities, severe inflammation, severe carditis, for example. So you start from steroids. You may start from steroids and then follow with salicylate if it's necessary. So arthritis or severe arthralgias and or mild carditis. We may start from big dosages of aspirin. You see the dosages of aspirin in adults and in children. So the most common duration of aspirin course is from 2 to 4 weeks. So we prescribe it not only to decrease fever, for example, and decrease pain, but we prescribe it for controlling of inflammation and affection of valves also. So anti-inflammatory drugs, aspirin in high dosages, it's a treatment, more often treatment of arthritis or severe arthralgia, and we may use it in mild carditis, which is also associated with arthralgia or arthritis. Some other non-steroid anti-inflammatory drugs which can be also used, it's naproxen. It's also investigated in this group of the patient. So you see the dosage of it, and duration is the same from 2 to 4 weeks. Acetaminophen is not effective for the acute rheumatic fever. That's why we don't use it. It doesn't control inflammation as we need. So the main is aspirin, naproxen. No, there are some recommendations about diclofenac, but in general, remember about aspirin and naproxen. So in severe carditis, when we see heart failure, when we see pericarditis, and if we see a poor response for salicylates, we start or continue with steroids. So we use the simple prednisolone. You see the dosage of it. You must remember that if your treatment of steroids is last more than a week, then you need to taper by 20-25% per week to prevent side effects and to control anti-inflammatory effect of steroids. So duration is the same, near to 2-4 weeks. You see that if inflammation is not suppressed after 2 days of classic scheme of steroids, you may use intravenously corticosteroids, pulse therapy, so-called, using methylprednisolone succinate, and you see the dosage, they are quite high. So for 3 days, such regime can be given to control severe heart failure, severe carditis, or if carditis associated with affection of other organs. We said it can be pneumonitis or nephritis or encephalitis, or so if polythyroiditis take place. So pulse therapy also can be used for the patient with acute and severe attack of acute rheumatic fever. Oral corticosteroids typically are given for 2 to 4 weeks, and as I said, we should taper the dosage of it another 2 to 3 weeks. Aspirin should be started when you start taper of corticosteroids and continue for 2-4 weeks after corticosteroids have been stopped. So also to control and maintain anti-inflammatory effects of steroids. For cardiac management, general recommendations also. So bed rest, of course, for the patient with heart involvement. If you see signs of heart failure, so of course diuretics, AC inhibitors, as for all heart failure. Sometimes inotropes if it's necessary, sometimes antiarrhythmic drugs if arrhythmias take place. But of course you follow ECG because of some problems of conduction, not only arrhythmias. Arrhythmias more often and problems in conduction, disturbance of conduction, it's a manifestation of acute myocarditis, and acute myocarditis is, as we see, we should treat quite aggressive to prevent further complications. How we can maintain patient with chorea? So in some cases, in severe cases, we need sedation with phenobarbital or valproic acid with diazepam, sometimes or chlorpromazine. Sometimes haloperidol can be useful in severe manifestation of chorea. There are some recommendations about intravenous immunoglobulins, steroids also, or plasmapheresis, but in general, efficiency is limited, and it's still under investigation, the efficiency of these methods. So mostly symptomatic treatment and, of course, control of inflammation by steroids and salicylates. Another quite necessary information, what you need to remember, that not only primary prophylaxis, but secondary prophylaxis is very important for the patient with previous acute rheumatic fever attack to prevent further chronic rheumatic heart disease. So if patient has rheumatic fever with carditis and residual heart disease, so persistent valvular disease, we need to make secondary prophylaxis for 10 years or until age of 40 years. Sometimes in some patients we need lifetime prophylaxis. If patient has rheumatic fever with carditis but no signs of residual heart disease, no valvular disease, so no echocardiography changes of valves, we make secondary prophylaxis till 10 years or until age of 21 years if it's for children and adolescents. Sometimes also can be this prophylaxis can be longer in some individual cases. And if there is no carditis in rheumatic fever, so we need to make prophylaxis, secondary prophylaxis for 5 years or until age of 21 years. But also secondary prophylaxis is very individual because of further manifestations and further flow of disease. If first attack finish without carditis, so next attack can be with carditis. So the main of treatment of acute rheumatic fever is to prevent residual heart disease, to prevent further destruction of valves. That's why secondary prophylaxis is not less important than primary prophylaxis. Maybe sometimes it's more important because this patient with chronic rheumatic heart disease needs surgery. They suffer from chronic heart failure with different arrhythmias. So the main idea of treatment of acute rheumatic fever is to prevent residual heart disease. So further exacerbations, further relapses of rheumatic fever. Sometimes patients with, as I said before, with severe valvular disease, some of these patients have lifelong secondary prophylaxis. And of course, if this patient has a contact with children, which are more often has carriage or gas of streptococcal infection, so this patient needs to be under secondary prophylaxis for whole their life. So remember it. And of course, most of our patients has their families, relatives with children. And if this patient has severe valvular disease, so lifelong prophylaxis, this patient needs. And you must explain the patient how it is necessary. So there are some regimes of secondary prophylaxis. You see what drugs we may use. It's a standard regime when we use penicillin G. You see the dosages. We have some alternative variants of secondary prophylaxis regimes also with penicillin B or sulfadiazine or sulfisoxazole. For patients with allergy for penicillin and sulfanilamide, so we may use erythromycin or azithromycin, but you should remember that the classic and the most effective is still penicillin group. That's why only if patient has allergy to this group, you must change it for erythromycin, for example, or azithromycin. And more often, we use prophylaxis each 3 weeks. So in some recommendations, once a month, but in general, better to use it every 3 weeks. Thank you for attention. Sorry for some technical problems why we started later, but it's not because of me. I was here in time, but and some computer problems give us some late because of it. So thank you one more time for attention. Good luck, and I hope that today's information will be helpful for you for further studying in our department. Goodbye.